Bismillahirrahmanirrahim. We are discussing disorders of the female genital tract. I am Dr. Pervez, Associate Professor Pathology, Jana Medical College, Peshawar. My dear students, in our previous lectures, I told you that for our convenience, we divide the disorders of the female genital tract into disorders of the vulva and vagina, disorders of the uterus and cervix, disorders of the fallopian tubes and ovaries, and disorders that are associated with pregnancy. Pregnancy occurs during the reproductive age of a female life. And the disorders that are particularly associated with pregnancy include inflammations and infections of the placenta, the pregnancy outside the uterine endometrium, that is, we say ectopic pregnancy, the gestational trophoblastic disease in the form of hydatidiform mole, which may be complete or partial, the invasive mole, choriocarcinoma, placental site trophoblastic tumor, and the toxemias of pregnancy that we know as preeclampsia and eclampsia. Today, from the disorders associated with pregnancy, we discuss the ectopic pregnancy. Normally, we know that during the menstrual cycle, at the end of the follicular phase of the ovary, mostly at the day 14, ovulation occurs. During ovulation, the Graafian follicle, which contains the mature secondary oocyte, ruptures, the ova is released, and if it gets the sperm, it becomes fertilized. Mostly fertilization occurs in the fallopian tube and mostly in the ampullary region of the fallopian tube. Once the ova is fertilized, this fertilized ovum then travels through the fallopian tube to reach the uterine endometrium. But during its passage through the fallopian tube, the ova undergoes certain changes. First of all, when it starts to divide, a two-cell stage known as the blastomeres, the two blastomeres then divide into 4, 4 into 8, and 8 into 16. And by the time it is 16 cell, it is known as the marola. And at this time, the ova is still in the fallopian tube. And through the ciliary movements of the fallopian tube, the fertilized ovum is propelled towards the uterus. By the time the fertilized ova reach the uterine endometrium, it is in the blastocyst stage, and it is the blastocyst form of the fertilized ovum which embeds in the uterus. So, if we say ectopic pregnancy, by that we mean that the ova implants somewhere outside the uterine endometrium. This implantation of the fertilized egg mostly occurs in case of ectopic pregnancy in the fallopian tube. 95% of the ectopic pregnancy occurs in the fallopian tube. However, the less common sites for the ectopic pregnancy may be the ovary. It may get implanted in the abdominal cavity and sometimes in the cervix. But remember two things associated with ectopic pregnancy is that the ectopic pregnancy is the one that occurs outside the uterine endometrium. You know that the ova and the growing ovum, the growing embryo, requires a lot of blood. And as its size is increased, the requirement for the blood is increased. So the two requirements for the ectopic pregnancy is that it is a fertilized ovum and it is resting somewhere outside the uterine cavity. And for the ovum to implant in outside the uterus, it must get implanted in such a site which is having a rich blood supply, because without blood supply the ovum will die and pregnancy is terminated. बेटा इसका ये मिसाल है कि हम एक छोटे से प्लांट को जब उसको वो हम कर देते हैं सॉइल में, तो उसको हम पानी और न्यूट्रिशन देते हैं तभी वो ग्रो करता है, और जितना वो ग्रो करता है उसकी रिक्वायरमेंट न्यूट्रिशन और वाटर के लिए ज़्यादा होती है। इसी तरह एम्ब्रियो को, ग्रोइंग एम्ब्रियो जो है ना, उसको ब्लड और न्यूट्रिशन की ज़रूरत है। तो एक ऐसे सरफेस पे जहाँ पे इसको ब्लड नहीं मिलता, न्यूट्रिशन इसको नहीं मिलती, तो ऑटोमेटिकली इट विल डाई। सो द पॉसिबिलिटी ऑफ ectopic pregnancy is that the fertilized ovum must implant in such a surface that is having a rich blood supply. The various surfaces where ectopic pregnancy can occur includes mostly the fallopian tubes. As I told you that 95% of the ectopic pregnancies occur in fallopian tubes, that is also known as tubal pregnancy. Rarely it may occur in the ovaries and sometimes in the peritoneal cavity and intestine. So these are the common sites for the ectopic pregnancy. Now we suppose that the ova has implanted somewhere outside the uterus and it has got implanted in a surface on a surface that is having a rich blood supply. So what will happen, that if the blood supply is not sufficient, if the tissue where the ovum, fertilized egg or fertilized ovum is implanted, is not going to supply enough nutrition and blood, what will happen, that the embryo will die. And on the second possibility, if there is sufficient blood supply to the fertilized ovum, what will happen, that the embryo will develop and it will form it will get divided into the trophoblast portion, which provides uh, nutrition and blood to the growing embryo, and where the placenta is formed. Now after the ovulation, the Graafian follicle is turned into corpus luteum, and this corpus luteum will secrete hormones like estrogens and progesterones. And because of these hormones, they the fertilized egg or embryo will grow. And as we know that during normal pregnancy, the first signs and symptoms that we see is the loss of menstrual period, that we know as the amenorrhea. And the pregnant woman during the initial days suffer from nausea and tenderness and fullness that the female feel in her breasts. Now we go to the outcomes of the suppose tubal pregnancy. The pregnancy has occurred in the fallopian tube. What will happen, that after some time, when the area or the wall of the fallopian tube, if it is not going to supply blood to the growing embryo, what will happen, that since you know that the space in the fallopian tube is not enough to support and to accommodate a growing embryo. So what will happen, that the fallopian tube will rupture, and this will lead to extensive bleeding, or we can say that there will be massive hemorrhage. Right? Now this blood flowing into the peritoneum will irritate the peritoneum, and the patient at this stage complain of severe pain, and most of the time the pain is referred to the shoulder. This is we say referred pain, and sometimes in such patient occasional slight to moderate vaginal bleeding may also occur. But remember that after ectopic pregnancy has occurred in the fallopian tube, and if the growing embryo cause rupture of the fallopian tube. It will lead to internal bleeding, and the patient will complain of severe lower abdominal pain, and the fallopian tube is damaged. And these three components, internal bleeding, severe lower abdominal pain, and damage that is caused to the fallopian tube after the rupture of the ectopic pregnancy, uh, they make ectopic pregnancy as a medical emergency. And in this situation, quick surgical procedures must be performed to save the patient life. Now, going to the causes of the ectopic pregnancy, the exact cause why ectopic pregnancy happens is not known. But there are certain risk factors that include smoking and history of PID, pelvic inflammatory disease, and in vitro fertilization, in which the ovum is removed and it is fertilized outside the uterus, and then again it is implanted in the uterine endometrium. And the other risk factor is the gynecologic surgery. And if the patient is having an intrauterine device that is commonly used for contraception, uh, it is also a risk factor for the ectopic pregnancy. And tubal ligation, which is done for contraception also, in which the fallopian tube is cut off and ligated, so automatically the fertilized ovum get no way to enter into the uterine cavity, and pregnancy occurs outside the uh, uterine endometrium, and it will be an ectopic pregnancy. And moreover, those patients who are having a history of previous ectopic pregnancy are more susceptible to a next ectopic pregnancy. In all these risk factors, we see one thing very common, and that is, if there is damage to the female genital organs or the female reproductive organs, particularly the fallopian tube, if it undergoes inflammatory changes and then followed by healing and scarring, and it will cause a resistance to the passage of the fertilized ovum into the uterine endometrium. And in this situation, it is the possibility of ectopic pregnancy increases. Now, going to the symptoms of the ectopic pregnancy, in the initial stages, when if the ectopic pregnancy occurs and if the embryo survives, if it gets enough nutrition and blood supply, it will lead to amenorrhea and loss of menstrual period that normally occurs during normal pregnancy. Pelvic pain is common, and sometimes mild to moderate vaginal bleeding may occur. Now, how we diagnose ectopic pregnancy? If we physically examine the patient, we may get a mass that is outside the uterus but near the uterus, and this mass is mostly palpable and it is very tender. And this physical examination may sometimes misguide us that the pregnancy is normal or it is inside the uterus. So the signs and symptoms that might make the normal pregnancy, they can cause a lot of delay in the diagnosis. We suppose that the embryo has implanted somewhere on a surface that is having a rich blood supply, right? So in these cases, the diagnosis is delayed if there is enough space for the ectopic pregnancy to occur, and it will take time before complications occurs. Now, when we make a diagnosis of the ectopic pregnancy, we suppose that we have two patients. One patient which is having ectopic pregnancy is hemodynamically stable. His vital signs like blood pressure, heart rate, and respiration, they are normal. And there is no fall in blood pressure or no hypotension, no tachycardia. So in this case, we will diagnose by regularly checking a serial human chorionic gonadotropin testing. And as in a normal pregnancy, the level of human chorionic gonadotropin doubles every day. And this is the situation that is also seen during a normal pregnancy. Now, you suppose that the human chorionic gonadotropin serial testing shows us an increasing level of the human chorionic gonadotropin, and then suddenly the level of the human chorionic gonadotropin drops. So in this case, we can see and we will observe the patient that if the placenta or the growing embryo is not developing normally, the serial human chorionic gonadotropin levels will fall. And we can here hope that the embryo or the growing fertilized ovum will die. We can also make a transvaginal ultrasound, and the transvaginal ultrasound is a type of ultrasound. Normally the percutaneous ultrasound may not be so much informative, but the transvaginal ultrasound will tell us in case of ectopic pregnancy that there is no gestational sac in the uterus, right? So in this case our patient is stable and we will wait for that the embryo will die and the pregnancy will get terminated. So in this situation we are going to wait and observe the patient. There is another condition in which we get a patient who is hemodynamically unstable, and this will be the situation, for example, during the uterine rupture. If there is bleeding, the patient will suffer from severe tachycardia, hypotension, and in this case this is a medical emergency, and we will refer the patient directly to the gynecologic surgery to remove the ectopic pregnancy for the purpose of saving the life of the patient. In this slide you can see that this is the normal uterus, these are the fallopian tubes, and this is the ectopic pregnancy or tubal pregnancy. The pregnancy has occurred in the fallopian tube, and here we can see the growing embryo inside the fallopian tube. Now, as we discussed that we have patients, the one which is hemodynamically stable, right? Then we will wait. And if we diagnose ectopic pregnancy, we will see initially the increasing levels of the human chorionic gonadotropin, and later on the human chorionic gonadotropin level will decline. And here we will wait for the hope that the embryo will die and the pregnancy will get terminated. However, in situations where we get a late diagnosis of the ectopic pregnancy, we will use the antimitotic drug known as the methotrexate that is used in anti-cancer therapy, and it will cause apoptic cell death. And in this situation, we hope that the methotrexate will cause death of the embryo and termination of the pregnancy. However, if we get a patient who is hemodynamically unstable, by what we mean that either there is fallopian tube rupture or expected rupture of the fallopian tube. So in this case, we will directly refer to surgery, and we can do salpingostomy, in which the abdomen is opened and the ectopic pregnancy is removed, and the fallopian tube is that is left left intact, so that in next pregnancies we may say that a normal fallopian tube will be there in the female genital tract. And in some cases, when it is not possible to remove the ectopic pregnancy, and if the patency of the fallopian tube cannot be assured, we will remove part of the fallopian tube along with the ectopic pregnancy, and this procedure is known as the salpingectomy. So in salpingostomy, we remove only the ectopic pregnancy and the gestational sac, but if we are not sure that we cannot save, or if we cannot sure the uh, persistence of the patency of the fallopian tube, we will remove part of the fallopian tube also along with the ectopic pregnancy. So coming to a summary of the ectopic pregnancy, we can say that ectopic pregnancy is the one in which the fertilized ovum is implanted somewhere outside the uterine cavity, and generally out of 100 only one pregnancy on average may occur as ectopic pregnancy. And the what is the most common site, that is the fallopian tube, known as the tubal pregnancy. The other sites, as we said, that it may be ovary, it may be gastrointestinal tract and peritoneal cavity. Now, salpingitis, which is an inflammation of the fallopian tube, and in its chronic form it will cause damage to the fallopian tube, causing adhesions and scarring. It provides a fertile field for ectopic pregnancy to occur, and particularly for the tubal ectopic pregnancy. Now, as I told you, that if the growing embryo runs out of space, automatically what will happen, that it will cause rupture of the fallopian tube, and in this situation we get a medical emergency, as there is internal bleeding, severe pain, and the patient is going to an unstable situation in which there is tachycardia, hypotension, and problems of the tract respiratory tract. And if we let this patient untreated, automatically it will lead to the uh, uh, death of the patient. Again, coming to summarize the ectopic pregnancy, as I told you, that there is no exact cause known exact cause, and however certain risk factors, including smoking, pelvic inflammatory disease, gynecologic surgery, presence of intrauterine device in the uterus that resist implantation of the fertilized ovum because of the presence of an external device in the uterine endometrium, and history of previous ectopic pregnancy. If a patient is having a previous ectopic pregnancy, it is a risk factor for the another ectopic pregnancy to occur. Now, the treatment, if the patient is hemodynamically stable, we wait, and we wait till the HCG level drops. And here we are hoping that the embryo will die and the pregnancy will get terminated. However, if we are going to make a late diagnosis, we can make the use of the antimitotic drug known as the methotrexate, which is normally used as anti-cancer, and it will cause apoptic cell death, and it will cause death of the embryo and termination of the pregnancy. In other cases, in hemodynamically unstable patients, we refer to surgery, and here we may do salpingostomy, in which the ectopic pregnancy is removed, and the fallopian tube is let to remain intact, or in some situations we may remove the fallopian tube along with the ectopic pregnancy. So thank you very much.